Welcome to our webinar, Beating Your Glaucoma Genes, How to Support Your Vision Health Despite Genetic Risk. My name is Brizette Castellanos, and I am the Digital Media and Engagement Manager at Glaucoma Research Foundation. Joining us today is Dr. Louis Pasquale. Dr. Pasquale is Site Chair of the Department of Ophthalmology at Mount Sinai Hospital, Professor of Ophthalmology, Artificial Intelligence, and Human Health, as well as Director of the Eye and Vision Research Institute at the New York Eye and Ear Infirmary of Mount Sinai. Dr. Pasquale's groundbreaking research, continuously supported by the NIH since 2006, has advanced glaucoma prevention, precision medicine, and the integration of artificial intelligence into clinical care and research. We are honored to have him with us today. Please welcome Dr. Louis Pasquale.
Thank you, Brizette, and I want to thank the Glaucoma Foundation for giving me this opportunity to speak with you today about beating your glaucoma genes. Here are my financial disclosures. And again, I'm fortunate to have support from National Eye Institute, Glaucoma Foundation in New York, and the Barry Center for Artificial Intelligence and Ophthalmic Health. So it is expected by the mid-2030s that a very large segment of the human population will have a scan of their human genome. And you will be informed about diseases that you're at risk for. And the question is, can you beat these genes that are predisposing you to disease? Now, this person, George Church, is one of my remote heroes. He's professor of biology, chairman of the Department of Biology at Harvard University. And here he's speaking to a staffer in Washington, D.C., and he's telling her that genetics is not your destiny. You can change it. And he's a genetic engineer. Let's show you some examples of beating your genes. So this is a disease called xeroderma pigmentosa. It's caused by a mutation in a DNA repair protein. Both of these children have the same mutation. The boy on the right has typical UV ultraviolet exposure, and you can see he has multiple disfiguring skin cancers. The child on the left has the same mutation, but yet she doesn't go out during the day. And in fact, she even wears this UV helmet at night, and she has pristine skin. So extreme ultraviolet avoidance created resilience to skin cancer that was produced by a genetic defect, which is destined to produce skin cancers in her case. Now, this is also true for what are called polygenic diseases. Xeroderma pigmentosa is caused by a mutation in one gene, but common complex diseases like hypertension, diabetes, obesity, and primary open-angle glaucoma are caused by many genes. So how do you develop strategies to beat these diseases, which are caused by the aggregate of many common variants in many different genes? Well, this is an example from the obesity literature. This data comes from the UK Biobank, where over 500,000 people supplied DNA samples. They also recorded the height and weight, and we know of hundreds of genes that contribute to your body mass index, which is your height, which is your weight in kilograms divided by your height in meters squared. So people with a higher genetic risk score for having a higher BMI naturally had a higher weight. And this data is showing that despite having a high genetic predisposition to being obese, if you exercised regularly, you could mitigate that genetic predisposition to being overweight. And, you know, that's common sense. And basically epidemiologic research should confirm common sense. But for each polygenic disease, the strategy that will be needed to mitigate against your risk from developing these conditions is going to be different. So let's just talk a second about a monogenic disease, which was that xeroderma pigmentosa that those two children had, versus a polygenic disease. The monogenic disease, if you have a gene that's normal, you don't get the disease. But if you have a mutation in the gene, the protein doesn't work right, and you develop a monogenic disease. Polygenic diseases work differently. They are the result of the aggregate effect of just modest variations in hundreds of genes, plus possibly environmental exposures that contribute to the condition. Now, what is meant by a variation in a gene? You know that in the year 2000, before that date, we didn't know the human genome code. There was a publication of the first human genome in the year 2000. And one of the things that we learned is that tremendous segments of the DNA are the same from one person to the next. This happens to be a monotonous strand of A, T, C's, and G's that are present in your genome along chromosome 7 in a gene called nitric oxide synthase 3. This is not important, but what is important is as you go along the read of the DNA sequence for this gene, everyone will have this exact same strand of A, T, C's, and G's, but then you'll get over here and 85% of people will have a C and 15% of people will have an A. And then you'll read another long segment of DNA. It'll be exactly the same from one person to the next until you get over here. And again, maybe 60% of people will have a C and 40% of people will have a T. These are called single nucleotide polymorphisms, and they occur in about 1 in every 300 bases along the genome. And pretty early on, people said, wow, this is very interesting. This might be the reason why common complex diseases develop, because if you have a significant number of these variants, this may contribute to you developing a disorder such as glaucoma. And in fact, I am part of an international glaucoma genetics consortium, and we've been trying to discover all the polymorphisms associated with primary open-angle glaucoma. And we've been quite successful at doing so. Over the decade, from about 2010 to current date, we have found over 300 common polymorphisms that contribute to primary open-angle glaucoma. What you see here is called a Manhattan plot. All the chromosomes are on the x-axis from the first chromosome to the last, and all of these variants are genes that are associated with primary open-angle glaucoma. Now, if you have a few of these, it probably doesn't cause glaucoma, but there gets to be a critical number of polymorphisms such that you are at increased risk for developing this condition. And in fact, we have done just that. We have worked to calculate a genetic risk score for glaucoma by summing up all of these different variants to give a person a risk profile for developing glaucoma. And this is occurring in other diseases as well. These scores are important. People with higher glaucoma polygenetic risk scores will develop glaucoma at a younger age. They will have higher intraocular pressure. They will have a higher propensity to require invasive surgery. So these scores have a clinical impact, and all of this is currently published. Now, the question is, how do you beat those genes? Or what is the relationship between your lifestyle and those genes in the development of glaucoma? Are there things that you do that would make your genetic predisposition, which is something you're born with, worse? And are there things that you can do to mitigate against that genetic risk of glaucoma? So we've done a lot of that kind of research. And in 2021, we published in Ophthalmology the relationship between a genetic risk score for having an elevated intraocular pressure and having glaucoma, and looked at it across the spectrum of how much coffee people drank. And we found something interesting. If you look here on the left, these are people, and they'll be the reference group, who have the lowest genetic predisposition to elevated intraocular pressure, and they're abstainers from drinking coffee. Compare those to people who drink more than 3 cups of coffee a day and have a high genetic predisposition to glaucoma. Those people are at fourfold increased risk of having glaucoma. And so the bottom line here, if you can learn anything from this slide, which is a little busy, is if you have a genetic predisposition to glaucoma, you should be drinking coffee in moderation, maybe 1 to 2 cups instead of 3 to 4 cups every day. Now, what's the story with alcohol? So basically, the bottom line is, regardless of your genetic predisposition to glaucoma, you should minimize your alcohol consumption. On the x-axis here is alcohol intake in grams per week, and data from the UK Biobank, and looking at people who were abstainers from drinking alcohol, who were the reference group. Those who were drinking more alcohol were at about a 40 to 50% increased risk of developing glaucoma. Now, this red line here is the US recommended amount of alcohol should be taken per week in men, and that's about 200 grams, or about a drink a day. But notice that people who are drinking alcohol at a rate that is recommended to be safe, there is a 40% increased risk of getting glaucoma. And no matter where you draw the line, the UK has a more stringent criteria for what it recommends for alcohol use. And for women, it's less than like 5 drinks in a week. And even if you adhere to that guideline, you are at a 20% increased risk of getting glaucoma. And your genetic predisposition did not matter. So again, regardless of your genetic risk for glaucoma, minimizing alcohol consumption is a good idea. Now, the next question is, are there metabolites that mitigate against genetic predisposition to glaucoma? And this is based on work that we just published in the April 2025 issue of eLife. And this is interesting. So this is Kiva Lee. She's a medical student at Mount Sinai, and she helped to do this data analysis from the UK Biobank. She found about 117,000 people who had DNA, reported whether or not they had glaucoma, but also had data regarding 168 metabolites that were measured in each case. So in this 117,000 people, about 4% had glaucoma and 96% did not. Now, what we did was we gave everybody in this cohort a genetic risk score for glaucoma. And we looked into people in the top 10% of genetic risk of developing glaucoma. In this group, 14.4% had glaucoma. Now, this compares to the people at low genetic risk for glaucoma. Only 1.3% had glaucoma. So this shows that the genetic risk score is capable of picking up glaucoma. And then we asked, is there something in the metabolites in their blood that is preventing them from developing glaucoma? And we found that there were 3 metabolites, lactate, pyruvate, and citrate, that were higher in the people who didn't have glaucoma despite a high genetic predisposition. And this result was statistically significant. This was pretty interesting. I almost didn't believe it. I was explaining these results to a colleague of mine at Columbia University, and he said, you know what, that's pretty interesting. we have a mouse model of glaucoma based on this gene called LMX1B. And LMX1B common variants are associated with a higher intraocular pressure and an increased risk of open-angle glaucoma. There are rare variants in the same gene that produces an aggressive form of glaucoma in childhood and young adulthood, and this condition is called nail patella syndrome. He told me that he put this gene in mice and he looked to see if pyruvate actually prevented glaucoma in these mice. And lo and behold, it worked. So basically fed half the mice pyruvate, just put it in the drinking water, and found out that either at 5 to 6 weeks or at 8 to 10 weeks, the mice that received the pyruvate, which would be over here, had lower intraocular pressure than the glaucomatous mice that did not have the pyruvate. So this was pretty interesting. Furthermore, looked at the impact of pyruvate on optic nerve health using a special dye. Basically, over 80% of the mutant eyes that did not receive pyruvate had either severe or very severe optic nerve damage versus only 51% of the pyruvate-treated mutants. So this work was an agnostic search of metabolites that might be associated with a reduced risk of glaucoma despite having a high genetic risk score. And we discovered pyruvate was one of those biomarkers who could do that. And we validated that pyruvate protected against glaucoma in a mouse model using a human relevant gene. So this is pretty exciting, I think, and it fits with some recent work suggesting that pyruvate might be useful in mitigating the risk against glaucoma. How does it work? In the anterior segment of the eye, it might be working to lower intraocular pressure by reducing what's called oxidative stress. In the back of the eye, the optic nerve has a high concentration of mitochondria. Mitochondria are like the little batteries that help cells to function. And so by generating ATP, which is basically the currency that the batteries need to keep running, this helps to reduce the risk of optic nerve degeneration. So you're getting a two-prong effect, a lowering of intraocular pressure and a direct protection effect on the optic nerve, which is why this may be working. So changing gears here to another subject, I know many of you have high blood pressure. And so the question is, what's the best blood pressure for optic nerve health? Now, this is data that we are generating from our genetics research, and we looked at the relationship between mean arterial blood pressure and global neuroretinal rim thickness in people without glaucoma. So here's a picture of the optic nerve, and this is the rim tissue. So there's OCT now. We could measure this exactly. And so what we did was, it was very simple. We just plotted out people's blood pressure versus the neuroretinal rim thickness. And we purposely limited to people who didn't have glaucoma. And in fact, these analyses are adjusted for glaucoma polygenic risk score. And what we found was here on the x-axis is the mean arterial pressure and the global neuroretinal rim thickness. This is data for the right eye, and we see a weak positive relationship between mean arterial pressure and global neuroretinal rim thickness. And the relationship is very strong for the left eye. So why is it stronger for the left eye? Well, if you know your anatomy of the great vessels in the neck, the blood supplying the left eye coming off the heart has a more direct pathway to the eye than the blood on the right side. But this is what this is saying, is that higher blood pressure, of course, within the normal range, is related to optic nerve structure, which is the site of damage in glaucoma. So therefore, low blood pressure or variable blood pressure could impair the optic nerve, especially in glaucoma patients. So while it's important to keep blood pressure under control if you have hypertension, you don't want it to be too low. So if you look back at this picture, you want to keep your blood pressure in here somewhere. This would be equivalent of 120 over 80 to about 130 over 85, something like that. That's sort of the sweet spot associated with a thicker neuroretinal rim to reduce your risk of having degeneration from glaucoma. Now, what about physical activity? Exercise is good. I encourage everyone to exercise. Physical activity lowers eye pressure. So if you were to go for a run for about a mile and recheck your eye pressure would be lower, but it would return right back to its baseline in about an hour. Furthermore, if you just take people who exercise all the time, and you measure just a random eye pressure, you will find that it's not much different from people who are sedentary. Furthermore, there's no association between glaucoma and a range of physical activity ranging from low to vigorous in the UK Biobank, and genetics didn't seem to modify these null associations. So, in conclusion, primary open-angle glaucoma is caused by many genes, hundreds of genes, and knowing those genes is turning out to be more and more important. High caffeine consumption increases the risk of glaucoma, especially in genetically predisposed individuals. Regarding alcohol, even moderate alcohol consumption increases the risk of glaucoma, regardless of genetic predisposition. Also, pyruvate, which is generally regarded as safe, may provide resilience to primary open-angle glaucoma despite a strong genetic predisposition to the disease. And finally, while exercise is good for cardiovascular health, right now, based on the best data we have, it doesn't appear to reduce the risk of glaucoma. So I just want to acknowledge a lot of people who are helped contribute to some of the research that I've presented today. Colleagues in New York and at Mass Eye and Ear also work with a bioinformatics team at Mount Sinai. And again, I am very fortunate to have support from the Barry Center and Glaucoma Foundation, Research to Prevent Blindness, and the National Institute of Health. So I'll stop there and be happy to take any questions.
Thank you, Dr. Pasquale. That was great. We have received a lot of questions, so let's go ahead and get started. So the first question we have, based on the findings regarding the Pyruvate and its potential benefits, what practical recommendations should be made to patients about how to obtain or incorporate Pyruvate into their daily lives?
That's a great question. And that was the first thing on my mind after we published this paper. And, so I still didn't believe the results. So this is what I did. I got a home tonometer and I measured my eye pressure 10 different times, various times during the day. And by the way, my mother has normal tension glaucoma. She has cold hands, cold feet, migraines, paracentral visual loss, frequent disc hemorrhages, and I got cold hands and cold feet too. So, you believe in genes. I'm in trouble and I need to beat my genes myself. Okay. And so I checked the pressures and then I went online and I bought Pyruvate from Amazon. And I'm happy to share where I got it from. And I took 750 milligrams twice a day for 3 days. And I repeated the measurements again, exactly the way I did it before. And the eye care tonometer doesn't lie. So before starting Pyruvate, I got 15. That was the average of both eyes checked 10 times. So it was like 20 measurements. After it was 13. So I really beginning to believe this. And so what I do in clinic is if I have people with a strong family history of glaucoma and I'm struggling to get their eye pressure lower, I talk about this with them. I tell them what I just told you about the study. It's off label. This is generally regarded as safe. It's over the counter. I have not had any side effects myself. I am continuing to take 750 BID twice a day. And I say, like you don't even need to worry about your calcium intake. It's only 17% of the USDA recommended calcium dose. And so for those people who are unstable, not at their target pressure, and have a positive family history, which is a pretty good surrogate for having a high genetic risk score, by the way, and that's based on evidence that's been published. That's what I'm doing. That's what I'm recommending. And by the way, I've seen an effect. I'm getting the same eye pressure reductions in these people. So I'm not, it's too soon to say, oh, their visual fields are better because I just started doing this. And I think, we need to do more research in a randomized clinical trial. But this is pretty interesting.
Thank you for sharing. Our next question is, are there any differences in the findings with normal tension glaucoma?
So I don't believe in the term normal tension glaucoma. And I get a lot of I don't see a difference between normal tension glaucoma and high tension glaucoma. Of course, the predominant pressures are normal in the office on those patients with normal tension glaucoma. But when I get a second opinion for patients with normal tension glaucoma, the first thing I do is tell them, are you interested in getting a remote tonometry? And let's see what your eye pressure is at 6 in the morning and in those pre-dawn hours. Very frequently, those pressures are in the 20s. And so, I think that, sure, there probably are some normal tension glaucoma patients whose pressures never rise above 21, but a good percentage of them have high tension at other times of the day. And I think that in my view, learning what I've learned about the genetics of glaucoma, that every patient is some composite of IOP, eye pressure increasing genes, and optic nerve degeneration genes. And that what normal tension glaucoma is are people who have maybe more of the optic nerve degenerating genes than IOP elevating genes. And there are probably some people have a full house match of the optic nerve degenerating genes and not a lot of the IOP genes. So that's my way of looking at normal tension glaucoma. And I don't even write the word in my chart. Everybody's primary open angle glaucoma, and I just want to know what was the highest pressure we know about in that patient. That's what I want to, that's my line. Primary open angle glaucoma, moderate phase, IOP max known, 21 millimeters of mercury. That would be a normal tension glaucoma patient for me.
That's quite interesting. Okay, so another question here. This one's about blood pressure. Are some blood pressure medications better than others for glaucoma suspects?
Yeah, we're finding that on the better side, we don't know. But on the concerning side, calcium channel blockers seem to be emerging as blood pressure medicines that are associated with increased risk of glaucoma. We're not sure why that's the case, but several studies now are suggesting that those are medications, blood pressure medications that you might want to stay away from unless your internist is at the end of their rope in terms of trying everything and they can't get your blood pressure down, because we don't want people to have a stroke. But if one could avoid the calcium channel blockers, that would be what I would do if I had hypertension at this point.
Thank you. Are some blood pressure medication, oh, sorry. It looks like we already covered that one. Does glaucoma skip generations or does it affect every generation?
It can skip generations. Again, the inheritance of primary open-angle glaucoma is complex. It's a polygenic disease. And it all depends on how genes are segregating, gene variants are segregating throughout the genome. You know, there are genes on every chromosome for glaucoma. And so it's possible that as genes rearrange themselves in one generation, you might have a lower genetic risk score. And in the next generation, you somehow have aggregated a larger number of those genes. It's not the simple, oh, I got this from my mother or I got this from my father. But certainly, if both parents have glaucoma, then it's more likely to persist from one generation to the next.
It's very interesting. At what age should children with a strong family history begin close monitoring?
That's also a good question. You would think that, oh, we should be watching people, you know, in their 30s and 40s, but that's turning out not to be the case. We did a study in the UK Biobank where we looked at the risk of glaucoma as a function of age and as a function of genetic risk score. And it seemed like older age amplified the genetic effects. You didn't see the opposite, where the younger people were more likely to get it. On average, the higher your genetic risk score, the earlier you're going to get the disease. But it's still not a disease that kicks in for the most part until you're in your 50s, unless you have unusual genetic variants that are contributing to the disease. So I think, if both parents have glaucoma, garden variety, primary open-angle glaucoma, regardless of maximum eye pressure, certainly in the late 40s, you want to start to get yourself an eye exam. But don't be surprised to find that that exam is totally normal and that you can go a whole, decade with your doctor saying, you're fine, you're fine, you're fine. And it's like when in the late 50s is when it really kicks in, at least for primary open-angle glaucoma. You don't need to rush your kids to the eye doctor unless you have one of these unusual congenital or juvenile open-angle glaucoma genes running in your family.
Understood. Okay, so are there ways to do a glaucoma polygenic risk score analysis? And if yes, where can we get the testing done for patients who do have family history?
So in the United States, there's no way to do it. But there is a company in Australia that will do it. It's called Seonix, Seonix, and it's seonix.com. And they'll do the test. They are charging $400. We still feel that more research needs to be done. And in fact, I was very fortunate with Dr. Janie Wiggs to have our NIH grant renewed. And one of what we did in the first round was call people from a biobank where they already had their DNA stored. We gave them a genetic risk score and see who had glaucoma and who didn't. And that paper's under review with Nature Medicine. 20% of people with the highest genetic risk scores had glaucoma, only 3% with the lowest had genetic risk score. So that's showing you that it works. In the next go around, what we want to do is take the genetic risk score right to the clinic and understand how knowing this information is going to impact the doctor and the patient. We feel that is needed. Might be jumping the gun here to make this, readily available. And but I can understand completely why people would want to know. I want to know my genetic risk score. And so I understand that. And if you are inclined in that direction, this company will do it. They'll charge you, and the insurance isn't going to cover it. But the thing about it is that this company is using the research that I just showed you on this slide. That's the basis. So it's not a fly-by-night company. They're going to give you legitimate information. They will give you a genetic risk score using the methods that I've just talked about, using the genes that I showed on the slides here today. So that would be how you would do it.
And once someone does get this information back, how do they introduce it to their ophthalmologist, or like what's the next step?
Yeah, that's why the US is saying slow down here a little bit. That's why we're funded to do the research to see how you're supposed to talk to the doctor and how are you supposed to talk to the patient about this. The answers to those things are not clear, but it's going to happen. So, I think that you will have two groups of patients. There'll be the worried well that, they may not have even a strong family history. They may just, have a cousin that went blind from glaucoma, and they're definitely afraid that they're going to get the disease. And so the genetic risk score could inform their risk and maybe allow them to sleep better at night if they have a low genetic risk score for the disease. The scoring is simple. It's like a test. You're either in the 1 percentile or you're, anywhere between that and the 100th percentile. If you're in the 100th percentile, you have a full house match of all of these genes. You have really high risk, almost to the point of like it behaves like one strong, rare genetic variant that causes an aggressive form of glaucoma. And everything in between. And we have to learn how to talk to patients about this. And we don't have that script just yet. The other side would be patients that have a high genetic risk score, and they may be not too concerned about their ocular health. And you have to say, hey, this is how people go blind from glaucoma. We catch it too late. And you have a strong genetic predisposition, and it doesn't mean you're definitely going to get it. And we could even talk to you about strategies to mitigate against your risk, but you need to watch it because this is exactly why people go blind from glaucoma. This is why we're doing this research. It's such an insidious onset disease. And so you need to be watched. So, I mean, that is the beginning of the answer to a very complicated and very good question. But these will be conversations that will be had. I think I tell people that this is going to become like knowing your intraocular pressure, knowing your genetic risk score is going to be an integral part of how you will interface with your doctor.
Thank you for that. We have a lot of questions about pyruvate, but before we get there, there was one here. So, okay, my ancestors do not have glaucoma as far as I know. I'm the first member of my family with glaucoma. Are my children at higher risk?
Assuming that you have primary open-angle glaucoma, yes, they're at higher risk. Just because your ancestors didn't have it, it doesn't mean that they didn't. Again, in older generations, we don't know what kind of eye exam people had. And we don't know their past ocular history, so it's not necessarily true that they didn't have it. Some people die young. People are living longer now. So maybe the ancestors died of a heart attack in their 50s. And so you wouldn't know if they had glaucoma or not. So, I think that though, if you have glaucoma, yes, certainly your children are at risk. So look at me, my mom's got glaucoma and I don't have it yet, but I'm concerned and I get myself checked. I'm 65 at this point. And so I'm concerned that I'm going to get it. So it's not something that plays out in the 30s and 40s on average. It's something that plays out in the 50s and 60s. So children don't need to worry now, but they need to be told about, glaucoma in the family for sure.
Can you also clarify, will the pyruvate work on its own, or should it be used in tandem with drops?
Absolutely in tandem with drops. This is not a substitute for medical therapy for glaucoma. Now, could it prevent glaucoma from developing in a suspect? We don't know that yet. That's an interesting study to do. But for people who have glaucoma, they must continue with their physician recommended therapy. When you ask me how I integrate it into my practice, I never tell people stop taking your Lumigan. I say, in addition to that, this is what you should do to help lower the eye pressure a little bit more and help to protect your optic nerve.
And I know you mentioned that you've talked to some patients, your own patients, about taking this. Would you consider some of their glaucoma severe, or was it not as severe? Like, would this work for glaucoma at any stage, would you say?
Yeah, I think it would work for glaucoma at any stage. The real question is, would it work for people who are not strongly genetically predisposed to the disease? Our data would suggest that it doesn't work for those people, but maybe it's not even needed for those people. But I have suggested it to people across the spectrum of glaucoma, and the data at my end, my trial of N equal to 1 on myself would suggest that it might even work in suspects. But it's not going to be a gigantic lowering of intraocular pressure, but that in conjunction what it might do to protect the optic nerve could be really important.
Understood. So we have a lot of questions around this topic. How can people with family history of glaucoma who are already experiencing the disease progression improve their outcomes? We just talked about this supplement. Is there anything else?
Yeah, again, coffee in moderation. If you're a big coffee drinker, 4 cups, go down to 2. Strategies that you might consider are, switch to decaf after the 2nd cup, switch to tea. Tea is, some data suggests that tea is good for glaucoma because of the bioflavonoids in tea. So, those strategies are very important. I hate to say this, but moderating alcohol consumption, which may be hard for some, is something that seems to make sense. Overall, the gastroenterologists recommend not drinking at all if you want to reduce your risk of colon cancer. I wouldn't go that far, but I would, think about moderating your alcohol consumption because regardless of your genetic risk, it does seem to increase the risk of disease. Um, I have done a ton of research about diet and glaucoma, and the only thing that we have come up with is that lots of leafy green vegetables appear to be good for glaucoma. And so I recommend that, but it's not my lead pitch because I don't see it having a huge impact. I'm seeing this pyruvate as being more important. And it might be because you saw the slide I showed. Hundreds of genes contribute to this disease. This is a disease where so many mechanisms are involved: oxidative stress, mitochondrial dysfunction, estrogen deficiency. And so all of these things are working together. And the one axe that looks like it breaks the Gordian knot is the pyruvate, because it's getting at the oxidative stress in the front of the eye and the mitochondrial function in the back of the eye. And so, of course, I still think eating lots of leafy green vegetables is good for you. It's good for macular degeneration. It's good for cardiovascular health. And I recommend that as well.
So we have a question here. Are there ongoing clinical trials about beating glaucoma genes?
No, that's next generation, but it's got to be done. That is fantastic question, right? I mean, and that's how you will get your answers fast, because otherwise glaucoma is like watching the grass grow. You need to get people that have really bona fide biological basis for having glaucoma if you want to do a glaucoma prevention trial. And I think that Pyruvate would be part of that. So it would be a wonderful study. You wouldn't take on all comers. You take on the people in the top 5% of risk of glaucoma. These are people that the genetic risk scores, by the way, are going to get better. The score that we have now, that's not the end all and be all. And that's another reason why the FDA doesn't want to be so quick to ratify a genetic risk score. Because remember, we said that right now, the top 10% of people are getting glaucoma at a rate of about 20%. We think, and this is part of the next grant, that if we add in more data about new genes that we're finding, we could make that number go up to 50% so that the test is even more efficient, right? So if you had a blood test that said you had a 1 in 2 chance of getting glaucoma and we had intervention X and we want to see if it prevents you from getting glaucoma, that's a dynamite study. But that's for the future, but it should be done.
Okay, so coming soon, hopefully. Have you heard of itronic nerve stimulation therapy? And if so, what are your thoughts?
I think that this is in the category of electroceutical treatments for glaucoma. I reviewed the literature on this and I'm underwhelmed. I'm not, criticizing the investigators, but I'm underwhelmed with the results of the studies. The data is short term and I don't doesn't look like it's a viable approach at this time. It's very strange, if you stimulate nerves with electricity, they will work better for a while. But glaucoma is a 24/7, 365 disease. So when you turn off this treatment, you seem to revert back to wherever you were, even if you had a short-term improvement in your optic nerve health. I remain open-minded to this approach, but at the current time, I'm not an enthusiastic supporter.
Understood. Thank you. Do you have any suggestions for patients who cannot use eye drops? Do you have any thoughts on SLT versus eye drops?
Yeah, I think that SLT is an excellent choice if you cannot tolerate eye drops. It's safe, it's effective, it's repeatable. Now we have data up to 6 years that the SLT can be repeated, and it helped keep people out of the operating room. It helped reduce visual field progression. So it's an excellent choice for patients who cannot tolerate drops.
Thank you. Are there ways to prevent having a child inherit glaucoma or its traits? Maybe something like CRISPR?
Yes. Okay. So I believe that the answer to that ultimately will be yes. And this is why, remember the first slide I said that by mid 2030s, large segments of the population will have their genome scan in hand. Guess what? In the United Arab Emirates, they're doing this now. 50% of the population has had their genes scanned. And one of the reasons why they're doing this is that they want to know about the rare Mendelian variants like the gene that produces that xeroderma pigmentosa. They want to know who has those genes in the population so that they can introduce marital counseling on the one hand, because maybe you need to have two genes in order to get the disease, but that would be for an autosomal recessive disease. But what about for autosomal dominant diseases? There's this technology coming down the pike where you can turn off bad genes. And they're considering this in aniridia. There's this transfer RNA that will walk through the bad copy of PAC6, which is the gene that causes aniridia, and turn it off. And so so there will be capability to do genetic engineering to fix rare Mendelian forms of glaucoma. Again, this is 10 years down the road, but it will be possible.
Thank you. Can you talk a little bit more? People are interested about caffeine. Can you talk a little bit more about caffeine and its effect on glaucoma risk and IOP?
Yes. Take on all comers. Caffeine does very little to intraocular pressure. But if you take people with a high genetic predisposition to intraocular, having elevated intraocular pressure, and you expose them to caffeine, that the genetic predisposition plus the caffeine gang up on one another to cause a high IOP. And if you're taking caffeine in through the whole day, maybe in the morning through coffee and in the evening, maybe through chocolate or dessert, you might be exacerbating your risk for getting glaucoma. We don't know exactly what the mechanism is. It's not a huge effect, but it's there. And it does seem to be important. I think that you're never going to see a randomized clinical trial about this, but if you're trying to beat your genes, again, I think I would be careful to cut down on the caffeine consumption.
Thank you. What is the TEK gene mutation and how is it related to congenital glaucoma?
So TEC is a Mendelian variant. It's along the lines of that gene that I talked about that produced the DNA repair defect. And it's important in normal tension glaucoma. So it is an optic nerve degeneration gene that can cause a disease that looks like glaucoma. And it is basically a form of glaucoma, but it's really rare. I've never seen a patient with it. I think in Iowa, they've published a small case series of it, and it's pretty interesting read. I don't know a lot about tech because it's just so rare. In fact, it wouldn't even show up in the polygenic risk scoring that we do. And in fact, the polygenic risk score that I'm talking about, it doesn't even include things like myocilin, which is the most common Mendelian variant for glaucoma. Now, what we want in the next generation of the glaucoma risk score is to include those rare variants anyway for those few people, so you capture the genetic risk related to those mutations.
Thank you. Can you talk a little bit about nicotinamide? Would you recommend patients take B3 supplements?
So not outside the randomized clinical trial environment, because unlike pyruvate, it's not generally regarded as safe. And in fact, within the trials that have been done out of Colombia, there have been a few cases of luckily reversible liver toxicity that occurred. So it is maybe very important ingredient as part of a cocktail that will help glaucoma patients. But I wouldn't go run into the drugstore and getting it at this point because of the potential side effects that it could have.
Thank you. Can a healthy diet and stress reduction slow glaucoma progression?
So yes, and I'm sorry I didn't cover stress reduction. That's really important. And there's studies out of India. They actually did randomized clinical trials where they had people going through guided meditation and they had lower intraocular pressures. And that's good enough for me because intraocular pressure is key in this disease. And, the thing about, doing these guided meditations is it is a time commitment. They're recommending doing 20 minutes in the morning and 20 minutes at night. And, it's really hard to sort of block out the world for 20 minutes and just focus on meditation. But the trials that have been done say that this is a worthwhile thing to do. So I apologize for not covering that. I guess it's my bias, but there are trials and they're not, it's pretty interesting data coming out of India that this could be very important. So if you've got time to do it, do it. It can't hurt and it could help.
Well, thank you so much. That concludes our Q&A section. Thank you all for making time to be with us today and for providing such helpful information to glaucoma patients, families, and friends.
Thank you, everyone. This was great.
Thank you once again for being here today and for standing with us in our bold vision of a future free from glaucoma. Because of your unwavering support, the cure is truly in sight.